Okay, in this segment I want to talk about how drugs work in a little bit more detail and routes of administration. So for how drugs work, of course, we've talked about we have a target and the drug binds. But let's think about that a little bit more because there are different things that a drug can do when it binds. Very often, the drug can be an antagonist. And an antagonist means it stops the protein from doing its normal function. So it decreases the function of the target. There are two kinds of antagonists. There are competitive antagonists and non-competitive antagonists. Competitive antagonists, what they're competing with is the normal pocket contents of the target. So in this picture, the drug is sitting in a pocket in the protein, and the idea is that there's another small molecule that's naturally occurring, say a vitamin. Let's say vitamin K. It's a small molecule, and vitamin K would like to be in that pocket. But because our drug is binding that pocket, it can't. So the drug and vitamin K are competing to be in that pocket. The drug is winning the competition, and so the vitamin K is held out. So that would be a competitive binder, a competitive antagonist. The other possibility is that actually vitamin K is perfectly able to sit in its pocket, but our drug is sitting somewhere else. This is often called an allosteric site. It's sitting somewhere else in the protein, and it's messing up the ability of the protein to function. So it still decreases the function of the target, but it's not competing with vitamin K. It's just messing vitamin K up. Okay? It's called an allosteric site because allostery is the idea that you can affect the structure of a protein at a site by binding and creating a conformational change in the protein that changes its structure and/or function. So typically, non-competitive would be an allosteric binding, and competitive would be in what we call the active site binding. By far, most drugs have a decrease in function of the target, but some are agonists. So an agonist increases the function of the target. In principle, agonists could also be competitive or non-competitive with whatever the natural molecules are, but we don't usually talk about that. There are also some highly specialized ideas. The one that I find most confusing is inverse agonist. And an inverse agonist binds the protein but lowers its function. But it's not antagonizing. So that's why I find it confusing. Let me go into a little bit of detail. Inverse agonist is really relevant when the target, it has a baseline activity, has baseline activity. That means at a normal physiology, the target is working and doing something. An inverse agonist will bind the target. The target will continue doing what it does, but it'll do it at a lower level. So we call it an agonist because it hasn't turned off the function, but it has lowered it. So here's what we have. So if this is activity versus time, we're sitting here at this level. We give our inverse agonist, and activity doesn't go down to 0, but it does lower. And that would be a special term reserved for these baseline activity targets. Our normal situation, of course, for antagonist would be it's doing its thing and then it goes down to a very low level. And for an agonist, it's doing nothing and it goes up with the agonist. So this is agonist. This is antagonist. and this is inverse agonist. The Wikipedia entry on inverse agonist, which I've recently reviewed, is pretty good. And so if you want to learn more about that, it's just to show you that things can get complicated. I think for most of pharmacology, the idea of antagonism and agonism is what you need. Second thing I wanted to mention in this segment is just to acknowledge the different routes of administration. We've talked about this a little bit before. Routes of administration for drugs. Oral, intravenous, sublingual, which is an example of mucosal delivery, mucosal, subcutaneous. The reason I wanted to discuss this is because these do have a little bit of different pharmacokinetics. So you will remember in our discussion of pharmacokinetics, we took an oral drug and there's a slow upswing and then there's a downswing. So that's oral. For intravenous, when you give the drug, you get an immediate up spike in the blood concentration and then some sort of drop-off. So the difference is this is a very fast upswing, where this might be relatively slower. For sublingual and subcutaneous, it's often things that cannot be delivered orally, but intravenous is a big deal. You need an indwelling catheter. So the nice thing about sublingual and subcutaneous is you can deliver biologics and other things that can't go through the GI system, but they will have a curve that is somewhat similar to the oral curve because there's a certain amount of time it takes to cross the mucosal barrier or to be absorbed from under the skin. And so it gives you a little bit of time for a slower upswing. So the fastest absorption would always be intravenous. Sublingual and subcutaneous would be fast, but a little bit slowed down, and then oral. And then, of course, drug companies are incredibly clever at mixing drugs with different delivery chemicals to make absorption faster or slower. One example is you can often suspend a drug in oil. If it's a hydrophobic drug, then what you will see is that it likes being in the oil, and it will only slowly leave the oil droplet into the bloodstream. So for some cases, you can take a drug and make it a slow release by embedding it in something like oil or some other delivery compound that allows it to seep out more slowly over time and therefore get a pharmacokinetic profile that is more convenient for the patient, for the provider, or for the physiological response. Let me see if that's everything I wanted to say. I think in previous discussions I've mentioned that when you take something orally, it is a mandatory first pass through the liver. All blood from the GI system goes to the liver first. So if the liver is extremely effective at deactivating a medication, then you have to give a big enough dose so that some of that medication gets through the liver to the rest of the body. So there's what we call this the first pass effect. And so many drugs, the dosing is determined by how much the liver is going to metabolize, and then making sure that you can give enough drug so that the liver is unable to fully metabolize it, so that some of the drug makes it through the first pass through the liver. Then it'll go through the body, and then the next time it comes through the liver, it'll probably be eliminated. So there are many drugs where you have to do the dosing based on the ability of the liver to get rid of the drug.